presented by the Laupus Library Diversity Committee. My name is Mary Roby, and I'm the Assistant Director for User Services here at Laupus, and I will be introducing our panelists for today. Dr. Eric J. Bailey, PhD, MPH, is a cultural and medical anthropologist, professor, author, and director of the Ethnic and Rural Health Disparities, or ERHD, graduate certificate online program at East Carolina University in the departments of Public Health and Anthropology. At East Carolina University, Dr. Bailey teaches undergraduate courses in the Department of Anthropology and graduate courses in the Department of Public Health. He is a joint appointed full professor at ECU. He is the author of 8 books, 2 book chapters, and 13 journal articles. Dr. Ronny Bell is an enrolled member of the Lumbee tribe of Robeson County, North Carolina. He is professor and chair of the Department of Public Health and associate director of the Center for Health Disparities in the Brody School of Medicine at ECU. Dr. Bell chairs the North Carolina American Indian Health Board and North Carolina Diabetes Advisory Council. Dr. Bell received his master's and doctorate from UNC Greensboro and received a second master's and completed a postdoctoral fellowship at the Wake Forest School of Medicine. Prior to coming to ECU in 2016, Dr. Bell was professor of public health sciences and director of the Maya Angelou Center for Health Equity at Wake Forest School of Medicine. Dr. Karlene Cunningham is a clinical assistant professor and vice chair of diversity and inclusion in the Department of Psychiatry and Behavioral Medicine. She has been at Brody for 4 years. Dr. Cunningham's clinical work focuses primarily on hospital-based consultation liaison with special interest in psycho-oncology, HIV/AIDS, sickle cell disease, and reproductive psychology. She complements this work with her research in sexual and reproductive health, implementation science, and graduate medical education. In her role as the chair of vice chairs of diversity and inclusion, she works with senior leadership at Brody to develop programming to improve awareness of diversity, healthcare disparities, and evidence-based interventions to enhance inclusion and belonging. After our panelists' presentations, we will have time for questions. Please type your questions into the chat box and we will get to as many of those as possible. Now, Carrie Forbes will be moderator today. Carrie is the liaison librarian for the College of Nursing undergraduate programs. Carrie, I'll turn it over to you now.
Okay, thank you so much, Mary. Can you hear me? Get a nod. Great, excellent. Welcome, everyone. We are going to start with Dr. Bell. Let me just make sure. I want to mention before we get started, the Laupus Library Diversity Committee brought this presentation together today, and the members of that committee are Jamie Bloss, Andrea Bristol, Lane Carpenter, myself, Alexis Moy, and Mary Roby. All right, Dr. Bell, if you'd like to get started.
Yes, good morning, everyone. I'm very honored to be a part of this discussion and a member of this illustrious panel. Very excited to see what kind of discussions we can have as a part of this session today. So I'll go ahead and get started. So next slide, Carrie. So I like to start when I have discussions on this topic. I like to start with this quote from Dr. Martin Luther King Jr. "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And I like this quote because it speaks to the depth and the breadth of the issues that we're going to be discussing. It speaks to the issue, I think, because of all the things that Dr. King dealt with in his life, his tragically shortened life. The one that he saw, in his words, as most shocking and inhumane was injustice, and is injustice in healthcare, and by extension, injustice in health. But it also, I think, speaks to the breadth of this issue, because if you look at the date on this quote, it goes back more than 50 years. And so this is an issue that we've been dealing with for a long time. So next slide. So I want to start you out with just a little brief quiz, and you can kind of think in your mind or write down your answer. I'll give you a couple of seconds. So true or false, American Indian babies in North Carolina are 50% more likely to die in their first year of life compared to non-Hispanic white babies. So Carrie, if you would show the answer there. So the answer is false. The correct answer is that they are 140%, or nearly 2.5 times more likely to die in their first year of life compared to non-Hispanic white babies. Next slide. So the second true or false question here is American Indian adults in North Carolina are 100% more likely to die from diabetes compared to non-Hispanic whites. Okay, so the answer there again is false. It is actually 140%, or 2.5 times as more likely to die from diabetes. Third question, next slide. Hispanics in North Carolina are 150% more likely to be diagnosed with HIV compared to non-Hispanic whites. And the answer there is false. They are actually 870% more likely, or 9.7 times more likely to die or to be diagnosed with HIV compared to Hispanics. So I think this sort of shows you, some of the issues that we're dealing with here in North Carolina, but also nationally. Next slide. And so when we talk about these issues, and Dr. Bailey will go a little bit more into detail about these definitions, but we talk about health disparities as these measurable differences in whatever measure of health status or even healthcare access that, and we typically talk about differences across racial and ethnic groups, but we also talk about those differences more pertinent to this discussion, talking about differences between urban and rural populations. But we need to sort of keep in mind these differences don't just occur by chance, that there are differences there that have historical and contemporary roots. And so we talk about then health inequities being the unfair differences that prevent everyone from having good health. And so now there is more and more discussion about this issue of health equity, which is defined as the achievement of the highest level of health for everyone, regardless of their status. Next slide. And so this graphic illustration, which probably many of you have seen, really points out the issues that, and so that the use of the young boys trying to watch a baseball game. And so equality refers to inputs. And so you can see that all three of the boys in the graphic on the left side have been given assistance to see the game, but the outcome, which is what we're most interested in, is different because the boy on the right is too short, even with the input from the box. And so equity means we want to have the same outcome. And so when we want to have the same outcome, then there needs to be opportunities to address those deficits to allow us to get to those outcomes. And then the graphic on the right says we need to eliminate those structural barriers that led to the deficit in the first place, which then gets us to these issues of equity. Next slide. And so there's been lots of discussion recently about what we call the social drivers or the social determinants of health. And so when we think about sort of what is really the underlying or upstream or root causes of these disparities that we see, we need to sort of think more in mind of what is the main driving force or the driving forces that contribute to these disparities. Next slide. And this is a really nice illustration, some work that was done by the Robert Wood Johnson Foundation and the University of Wisconsin Population Health Institute, which broke down, if we take two of the most important public health indicators, length of life and quality of life, we see that the biggest contributor to those two public health indicators are social and economic factors. So 40% of what we believe drives differences in length of life and quality of life are not related to clinical care or health behavior or physical environment. It is the social and economic factors in our society. Next slide. And this is particularly important because as we think about issues around healthcare costs and health expenditures, which is dominating a lot of the discussions we're having on the political arena, we know that in the United States we're not getting the bang for our buck, that we far outspend other countries, other industrialized countries for healthcare expenditure, but our life expectancy doesn't really reflect that. So we're kind of in the middle, despite the overwhelming amount of money that we spend on healthcare in our country. Next slide. And so health equity, really, this is a nice definition from my colleague, Cornell Wright, who's the executive director of the North Carolina Office of Minority Health and Health Disparities. He says that health equity is not the sole responsibility of one individual or one agency, but is the collective responsibility of us all to do better, to be better, and to help others. Next slide. And so this involves then how do we get to this lofty goal of everyone having the highest level of health? Well, it takes more than just the individual making changes. It means changes at the interpersonal level. It means changes at the organizational level. It means changes at the community level. But I would say most importantly, it means changes at the policy level. And that's policies in our local municipalities. It's policies in our counties and states, but also policies at the national level. Next slide. And I think there's been a lot of efforts to try to point out these issues as it relates to social determinants and health equity. Dr. Cunningham will show you some data later from the Racial and Ethnic Health Disparities Report from the Office of Minority Health in North Carolina. But they have, in addition to pointing out some of the health disparities across the major racial and ethnic groups in North Carolina, they also indicate some of the social determinants that differ across racial and ethnic populations in our state. Next slide. And I was very fortunate to co-chair the Healthy North Carolina 2030 Task Force that met this past year, and we put together a report that sort of broke away from the traditional reports, the Healthy People reports. What we did this time, next slide, is that we focused on the social determinants. So that report, diagram from the Robert Wood Johnson Foundation and the University of Wisconsin, we really broke those down and said, what are some key indicators that we can look at here in North Carolina? And I know that the print is really small, but I would encourage you to go online and take a look at this report and see how we broke down each of the health indicators. So we didn't just say, we want to see cancer deaths decline or heart disease deaths. We said we want to see changes in our social and physical environment that's going to lead to long-term changes in the disparities that we see. Next slide. And so this is just one example where we looked at life expectancy, which is one of the two public health indicators that we consider in our country. And then the next slide. Next slide. So infant mortality. So for each of the 22 health indicators that we broke out, we put these goals in place to say this is where we want to see changes occur, and this is how we feel like the underlying social factors in our society play a role in that. Next slide. And the CDC is really taken to heart how we can be more proactive in achieving health equity by developing a health in all policies effort, where the goal is really to bring people together from all walks of life to try to ensure we are focusing on the areas, the social factors, the physical environment factors, the health behavior factors, and the clinical care factors, that we have a collective focus on these issues so that we can achieve health equity in our communities. Next slide. So I'd just like to leave you, and I'm looking forward to our discussion. I'd like to leave you with this quote from Dr. Maya Angelou. I had the privilege of working with her during my time at Wake Forest. One of her favorite quotes was, "Courage is the most important of all the virtues, because without courage, you can't practice any other virtue consistently. You can practice any virtue erratically, but nothing consistently without courage." So it really takes courage on our parts to say, you know, our societies are broken and they're causing people to not live healthy lives. And we need to be proactive in making sure that we're making the changes that we need to achieve health equity. So thank you.
Thank you so much, Dr. Bell. Dr. Cunningham.
Hey, thank you so much for having me today. I'm so happy to kind of talk a little bit more about some of these rural and minority health disparities. I'm specifically going to focus most of my talk today on mental health aspects. And so I'm happy to dive in. Next slide. So as Dr. Bell has already kind of talked about, we have our health equity, our health inequalities, and health disparities. And again, here we have similar definitions just to kind of remind us. Next slide. And Dr. Bell pulled out many of the kind of social determinants of health, and I pulled out a few that I wanted to talk a little bit more about, as sometimes people do not connect these with the aspects of mental health, mostly just kind of physical health. So when we think about things like access to healthy food, there are several food deserts, so areas where residents lack access to, grocery stores, or where people are able to get fresh foods and vegetables. And also there's the aspect of hunger that can also happen in these areas. Within the areas of mental health and what we've been looking at recently, we see that there is, again, a very large tie between what people eat and how they feel. And so if we are already in areas that lack access to good nutrition, healthy foods, fresh vegetables, we are also then building the building blocks of how people are feeling in their bodies, as well as how they're feeling mentally. Similarly, when we think about environmental conditions, there are areas that have limited access to parks. There's not a safe place to walk. And one of the things that we know is very key to overall kind of well-being, both physically and mentally, is physical activity. There's several studies out there that are looking at exercise and how it can be an adjunctive treatment for depression, anxiety, the aspects of enough tree cover. So there is greenery outside can really help to reduce feelings of stress. And it's actually one of the reasons why many times when they're trying to rejuvenate or re-energize an area, they are working on increasing the tree cover, the plant cover, and those kind of aspects to give people a sense of safety. And then, of course, we have access to healthcare. And there are shortages in healthcare providers across many of our disciplines, but specifically within the area of mental health, we see a very large shortage of providers. As well, when we start to think about the patients that we tend to see, there is a lack of representation amongst the providers that provide mental health. So people coming in wanting to feel safe, wanting to feel like someone understands, don't often kind of see people that maybe look like them on the other side of the desk or within the hospital or within the white coat. And that can definitely be very impactful and a large barrier for people being able to get the help that they need. Next slide. So from that equity report that Dr. Bell had mentioned, they had a really nice diagram looking at the areas of disparities across racial and ethnic groups. And so this just gives you a visual representation. So the red areas are where there are significant group differences, so that the indicated group is doing far worse than the referent group. And so if you look at just, say, African Americans across the board, apart from suicide, they're faring far worse. Similarly, amongst American Indians, there are some places that we, don't have enough data to really indicate, to calculate enough. And then we also have areas where they're doing a little bit better. For our Hispanic and Latinx communities, similarly, some areas of differences. And what I like about this is that there very little words need to be kind of said just to be able to see this impact of how things are different depending on your racial or ethnic background. Next slide. So thinking more about mental health in North Carolina, estimates suggest that about 1 in 5 North Carolinians have a mental health diagnosis. We see that there are some racial and ethnic minorities maybe tend to have lower prevalence of mental health disorders, but I have to caveat this in that there are individuals that might be experiencing mental health issues but are not getting connected to be able to have the diagnosis. And then those that are diagnosed and connected, we do see that there's some diagnostic disparities that exist. So for example, we see within attention deficit and hyperactive disorder, we see that boys and girls of color tend to be more likely to be diagnosed with, say, a conduct disorder, even though their symptoms may be more consistent with ADHD. And we see, again, similar, if we gave a case to a provider to look at that exactly the same, but the only thing that's different is the racial or ethnic background, we see an overall difference in terms of assigning those behaviors to maybe conduct versus ADHD, as well in other diagnoses in terms of things of psychotic issues, so like say schizophrenia. We also see a potential overdiagnosis of thought disorders amongst African American populations. And we also then see there's an issue of access for our rural areas where individuals in rural counties are more likely to visit an emergency department for a mental health reason. Again, highlighting a fact where they may have not been able to access mental health care within their community, or there were barriers that prevented them from doing that so until they are presenting with a very serious mental health problem, likely suicidal ideation. Next slide. So looking at the Healthy North Carolina 2030 Pathway Toward Health, again, had some very amazing graphs and dialogue about these indicators and showing some of these differences. So first I wanted to kind of think about insurance. Insurance has to be one of the main factors that tends to be your ticket in the door of being able to connect with healthcare. Healthcare on its own is very expensive, as many of us, most of us probably understand and know. And we have a very high uninsurance rate here in North Carolina. So the target at this point is to be able to get down to about 8% by 2030. We're currently around 13% uninsured, but this rate then varies based off of race and ethnicity, gender, and of course, poverty level. So seeing that these numbers speak a very louder story, especially when we start looking at the intersections of for an individual. So maybe their ethnicity and their sex, as well as their poverty and what that looks like. Next slide. For us here in Eastern North Carolina, the thing to kind of look at is, so look at these counties that make up the East. We see a lot more or a lot higher rates of uninsured in those counties. So thinking about the area of which Brody School of Medicine and Vidant serve, we are seeing a larger proportion of individuals that are uninsured. Next slide. So one of the hallmarks or one of the key indicators that's often pulled out for mental health is deaths by suicide. And as you can see with this graph, we have individuals that are white at the higher rates of death by suicide, and also men tend to die by suicide more often. So if they are making an attempt, their attempt is likely to be more successful. And when we look across these numbers, we also notice that there's a story that's also not necessarily told for other groups. So looking at veterans are often at a higher rate of death by suicide, given that they have had some training, had greater access to highly lethal means like guns. Residents that are living in rural areas oftentimes have higher rates of death by suicide. Our LGBTQA+ communities, and also American Indian communities. Again, data not available here, but in other research has suggested that deaths by suicides are also higher. One thing that this is also not highlighting are those that are making an attempt that is not successful. So the idea that just the death by suicide and not getting to a place low enough to be able to say life is not worth living is also a very important indicator. And we find that females tend to have more attempts. And we also see that there are increasing rates in our minority communities in terms that it used to be thought of as a protective factor of being from an ethnic or racial group. But we're seeing, especially amongst our teenagers, increasing rates of suicide attempts and deaths by suicide. Next slide, please. And so I had noted the idea of just mental health provider shortages. And to really kind of hit this home, here's a graph or an image looking at our state and the number of counties that are indicated as mental health shortage areas. And most of them are. And there are certain counties that don't have any psychologists or psychiatrists within the county, and is one of the reasons why we are trying to expand through technologies like telehealth and telepsych to be able to reach those counties that have very limited means of connection with a behavioral health or mental health provider. Next slide. So say that there is individuals that have the golden ticket, so they have insurance, right? And say that maybe there even is a provider within their community. Are individuals, especially those of racial and ethnic minorities, actually getting the treatment that they need? And we tend to find that no, that they're not. And so what we're looking at here is just a graph looking at the consequences and disease burden. Treatment gaps amongst African Americans remain vast. And so if, for example, any mental health illness for an individual 18 years and over that is African American, we see that 69.4% of them would not actually access treatment. And this could be for a variety of reasons. And when we look at co-occurring any mental health illness plus substance use disorders, we're finding that 91% are not getting connected or not getting the treatment that they need. These treatment gaps are huge. And especially now in the time of COVID, we find that this is potentially a kind of a double whammy, that we are in a very stressful time for all of us, and the need for getting connected to mental health services and support are even greater. And so if this is what things looked like before, it's hard to say, you know, this could only be worse now as we have more limitations oftentimes in getting connected and getting to the places that we need. Next slide. And so this is the same slide just for Hispanic communities. And we see that the treatment gaps here as well are very high. Next slide. So all of this is a very complex system. And some of the barriers that often come up is just really even understanding how to access health. So within North Carolina, there are many hoops that folks have to be able to go through to be able to get connected. We have a tapestry of local management entities and managed care organizations, often referred to as LMEs or MCOs, that people have to then connect to maybe find a provider if they're, say, on Medicaid or Medicare. They then potentially, you know, finding an individual that takes their insurance and can see them and has openings can be very difficult. And once finding the right fit, because oftentimes, you know, you don't connect with the provider that you happen to find. And the rapport between an individual and the patient, or individual and their provider, is very important in terms of being able to talk about some of these more difficult aspects. There seems to be difficulties with coordinating between primary health care and mental health care. There are very big initiatives right now trying to integrate behavioral health and mental health providers within the primary care areas, so people don't have to go to a specialty care mental health psychiatric location. So they get their care where they get their regular checkups. Previous to COVID, there had been very limited ability to expand telepsychiatry or telemedicine within North Carolina because of some barriers and insurance companies paying for services where the patient is or individual is not in a clinic. Many of these things have been relaxed given COVID, and we've actually seen an uptick in individuals being at one, keeping their appointments when they have them, and those reaching out to be able to get services now that they can have it within their homes. There's also a lot of stigma related to mental health disorders. I could do a whole talk on the historical backgrounds of what mental health was looked like in the early days and how it was separated. But for time, we'll just leave it at there is a pervasive just stigma for individuals even admitting that they have mental health issues, much less than seeking treatment and stating that there is a problem. And there's also a lot of mistrust. So I talked earlier about how there are some diagnostic differences and biases that sometimes pop up, and there has been historically a lot of fear in terms of utilizing psychiatric conditions or diagnoses to other people, attempt to even identify what is quote unquote wrong with minorities. And this mistrust definitely kind of continues to persist. And we're working every day to try and overcome that mistrust and gain the trust back of our minority populations, so that we can provide the resources and the treatment that is needed where people are at.
Thank you so much, Dr. Cunningham. All right, Dr. Bailey.
Hello. Thank you. With the time remaining, I want to make sure I get through all of my slides. Again, welcome everyone. Thank you for allowing me to be a part of this roundtable discussion. And again, I'm the director of the Ethnic and Rural Health Disparities Graduate Certificate Online Program. You can see my website right there. Please go to it after this roundtable discussion. Next, please. I'm going to go through some definitions and issues very fast. Next. I'm trained as a medical anthropologist. So what is a medical anthropologist? A person who specializes in focusing upon health and medical issues of all racial and ethnic populations from a biopsychosocial cultural perspective. Next. Medical anthropology is a subspecialty of anthropology, which focuses on health, disease, illness, medical problems, theories of illness, and healthcare systems in different cultural and ethnic groups from a biopsychosocial cultural perspective. Next. In essence, this biopsychosocial cultural perspective highlights key factors such as biology, of course, psychology, sociology, and most importantly, culture and cultural issues. And that's what I want to emphasize in my particular talk. Next. Additional factors: religion and spirituality, economics, education, politics, history. Next. And the medical anthropologists we obtain our data through field work. We actually do observation, participant observation, qualitative research. We sit down with conduct focus groups, individual in-depth profiles. So this is how we obtain our data. Medical anthropology is basically for 4 major disciplines: ecology and epidemiology, medical aspects of the social cultural system, medicine and acculturation, and ethnomedicine. I like to emphasize ethnomedicine. Ethnomedicine is how individuals think about illness and how they organize themselves toward treatment. Ethnomedicine. We know what public health is: the science and art of preventing disease, prolonging life, promoting health and efficiency through community health. Next. The major functions of public health, which I emphasize to my students in all my classes, is assessment, policy development, and assurance. Next. And this is a slide where I was at I'm a health scientist administrator at the National Institute of Health, where I was a health scientist administrator and program director for 5 years, from 1999 to 2004, which I worked for the National Cancer Institute and the National Center of Minority Health and Health Disparities before it became an institute. And that's when I recognized the importance of public health on a federal level, because on a federal level, individuals look at data, the large-scale data as well as policy. And if you got to have lots of data on particular health disparity groups and also leadership, effective leadership to push a certain policy. So that experience that at the federal level at NIH really opened my eyes up to health disparities on a national basis. Next. So let's look at, again, I always like to slow things down a little bit, particularly when I teach my classes, my graduate students. You got to slow things down because everyone is in so much of a hurry. I say, slow down. Let's look at the definition of health disparities and healthcare disparities. Next. Health disparities is defined as differences in incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. This is the NIH definition. Next. Health disparities, highlights differences across racial and ethnic groups, differences across among rural, urban, socioeconomic level, age, gender, LGBTQ population, differences among all groupings. And here's the big caveat. Everyone, each and everyone is a part of some type of health disparity group. So it's not just a particular group, it's everyone. And when I share that with my students, they're surprised that they are part of a health disparity group. Next. Healthcare disparities emphasizes differences in access, differences in use, differences in quality of care, differences in outcome of health and or medical care. That's very important to distinguish health disparities and healthcare disparities. We're looking at access, use, quality of care, and outcome. Next. The examples of healthcare disparities. For example, racial and ethnic minorities have significantly worse access to healthcare compared with non-minorities. Racial and ethnic minorities have lower rates of healthcare services compared with whites. Next. Racial and ethnic minorities are more likely to be uninsured, just as Dr. Cunningham indicated. Racial and ethnic minorities are more likely to not have a usual source of care. Racial and ethnic minorities tend to receive lower quality of care. Next. Racial and ethnic minorities are more likely to experience communication problems with their care provider. Very important, communication. Racial and ethnic minorities are more likely to feel uncomfortable asking their healthcare provider questions. Next. So I go to this 1986 report task force on Black and minority health. Next. This is the document. I use this in my class, in my ethnic health and health disparities class and my African American health class. This Black and minority health document from the federal government, published in 1986. This was the first time that disparities was mentioned in the federal documents. Because why? They recognized, they did a report right before then, and the health report, healthy, whatever it was, said that most Americans are healthy, improving, but they realized there was a certain segment of the United States, Black and minorities, that were not achieving the health equity as many others. So they offered they arranged a new panel, Secretary Task Force, a new panel, and they came up with this major document which changed the landscape, changed the vernacular, changed the attention on the issues of health disparities happening among Black and minority populations in the United States. That was 1986. Next, definitions, culture, cultural attributes, and cultural competence. Next. I always emphasize culture and health. There is a connection. Somehow we forget that culture and health are interconnected at each and every day of our life. Next. Culture is a system of shared beliefs, values, customs, traditions that are transmitted from generation to generation through learning. Next. Cultural attributes are learned, transmitted by symbols, adds meaning to reality, integrated, differently shared, and adaptive. Next. Cultural competence, and this is where we're trying to make a lot of programs nationally and locally culturally competent. Culturally competence is defined as the ability to work effectively across cultures in a way that acknowledges and respects the culture of persons or organizations being served. Next. It's also a set of congruent behaviors, attitudes, policies that come together in a system, agency, or among professionals, and enable the system, agency, or those professionals to work effectively in cross-cultural situations. Next. on an ongoing, and as well as cultural competence, is ongoing and interactive process based upon respect of other customs, beliefs, and values. Next, the major components, break it all down, all that verbiage, break it down to 3 components: knowledge, attitude, and skills. Knowledge, attitude, and skills, very, very important. Next, how do you make the programs culturally competent? Respect cultural differences. 2, accumulates continual knowledge of local health disparity communities. And 3, recruits and retains diverse staff. Next. And of course, like I said, cultural competent public health programs for health disparate populations, and the Affordable Health Care Act, which is being debated upon even today. We're talking about affordable insurance for everyone, access for everyone, and quality of care for everyone. Okay, affordable insurance, access, and quality of care. Next. My take-home message is health data indicates continual significant health disparities in all major diseases. No doubt about it. However, health data indicate positive behavior, positive patterns of health. Let me just say this. Many times I shock my students saying there's a lot of positive health behavior that's happening in communities of color, in racial and ethnic populations. And I shared this, and there's a surprise because usually they only hear negative health disparities among racial and ethnic minority populations. Guess what? There's a lot of positive data out there. It gets overlooked. So I slow my students down and look at the positive patterns of health behavior. Next. Health disparate populations are very diverse biologically, psychologically, socially, and culturally, and implementation of more culturally competent programs are needed. That's my bias. Cultural competent programs are definitely needed, and it's also, there's data in the federal government that shows programs that are culturally competent somehow do much better, and the data is there in the federal government. Next. Understanding the relationship of culture and health is vitally important. So I say we need to go a little bit further than social and economic determinants. We need to incorporate cultural patterns, cultural systems into our programming and further development. So that's my bias. Culture and health are extremely important. And all of my students in my classes understand that I drive this message home, and they remember it, particularly at the very end of the class. So culture and health is significantly important. Next. That's my presentation.
Thank you so much, Dr. Bailey. All right, now we're going to take some questions. I saw one here in the chat from Dr. Savitt. So panelists, feel free to answer if you feel like this works for you. The question is, in what ways is the ENC rural area different from other rural areas in terms of mental and physical health? And does rural ENC pose different challenges from other rural areas to health workers?
I'll take a shot at part of that. I think maybe Dr. Cunningham can address the mental health issue, but I know that a few years back we looked at data looking specifically at ENC as if it was a state. And if you looked at like life expectancy, heart disease, cancer, sort of some of the general public health indicators, ENC would rank like in the bottom 5 of all 50 states if ENC was a state in and of itself. So I know that it is relative to other rural populations in the country, it is a pretty disparate area. It's a different area just because it's not mountain rural, it's not frontier rural. It is, I think, similar to maybe some of the rural areas of like Alabama or Mississippi or Arkansas. But there's clearly, I mean, Eastern North Carolina is, I think, the only area in the United States that is part of the stroke belt, the diabetes belt, and includes a colorectal cancer hotspot designated by the National Cancer Institute. So
Yeah, and so from a mental health perspective, there definitely are shortages in other rural areas. And having worked in rural Alabama during parts of my training, I definitely have noticed some, like anecdotally, noticed some differences in terms of ways to access. There has been historically a lot of different moves and shaking and kind of policy making in terms of what to do and how to provide access to mental health care. But some boons that we do have are things like the R program in NC STEP, headed by Dr. Saeed, in terms of a national network of being able to connect hospital emergency departments with psychiatrists via telemedicine, telepsych, and being able to do those evals to get individuals out of the hospital or to the appropriate disposition earlier. And that is actually a national model and is very well regarded and has saved a lot of money and a lot of lives in terms of being able to improve that quality. And that is continuing to be expanded. So I think that we have some unique challenges, but also some amazing people and colleagues working together to be able to address those.
I would like to add to that yes, the ENC is very distinctive, unique. However, when you look at communities globally, and this is what I always teach, globally, there's rural communities in a lot of other countries that come up with distinctive elements, distinctive factors, which make their situation very similar to what's happening to the ENC. And that's where it's always refreshing to do a very comparative approach, not just in the United States, but globally. And then you start to see that these elements, these things that we feel that is very unique and the health disparities is happening here, guess what? It's happening elsewhere. And we can see the same dynamics happening in other rural communities in other countries. And they're asking the same questions and they're saying the same thing. There must be something unique in this other country. I go through several countries. As a matter of fact, I'm teaching global public health right now, and we're going through several countries. And my students are surprised of the health disparities, the rural health disparities that are happening in countries such as United Kingdom, Sweden, Japan, and all different types of countries. I just go down the list and they're just completely surprised.
Thank you, Dr. Bailey. I have another question for you from Kim Stokes. Do you recommend a lens of cultural competence or cultural humility?
Good question. Cultural humility, both. You have to do it both. It's not one or the other. It's both. And that's the challenge. And one thing about teaching this class for since 2006, since I've been here, and it's in our program since 2010, and I've been teaching health disparities since the 80s. Things I always emphasize, you have to come to grips with your own biases first. Cultural humility. Everyone has biases. It's okay to admit it. So you can recognize your biases, be humble, then make the steps to develop strategies, improve your knowledge, attitude, and skills in making your program and your perspective culturally competent. So all of us, no one is excluded, needs to be cultural humility, humble, recognize your biases, and then take the steps to be culturally competent. And that includes not just yourself, but the community. The community needs to increase their knowledge, their attitudes, their skills in working with our mainstream institutions, because that's where the distrust and the stigma and all of that, the lack of participating in our healthcare system locally, here in the ENC, in the state, you have to work in all communities. So it's just not from the healthcare professionals. It's the community needs to, again, increase their knowledge, attitude, and skills in working with those of us who are at ECU and elsewhere.
Thank you.
I would say you can't be culturally competent without being culturally humble.
Another question we have is from Fernando Chavela. What current interventions are being applied to address these issues of health disparities? Are there research opportunities that address these issues here at ECU?
Well, maybe Dr. Cunningham can talk about the telepsych program. I can say the community service learning centers through the ECU School of Dental Medicine is a tremendous opportunity both to provide clinical oral health care in Eastern North Carolina, but also research opportunities. So I think that's a huge one, but maybe Dr. Cunningham can talk a little bit more about the telepsych.
Yeah, so in NC STEP, they do a lot of research in terms of the data that they're collecting clinically. And so there are research opportunities to be able to work with that team and be able to assess kind of some of the differences there. I know that there are also opportunities in several other areas. I know that there are researchers that are looking at disparities in cancer care, and we have a health disparity cluster at ECU. So, I think that being able to kind of connect in and go to our kind of Redis or our research website to be able to look at throughout ECU some of the things that people are doing, but definitely a very hot topic at Brody School of Medicine and throughout the ECU community.
Thank you. I have another question from one of our diversity committee members. Can you talk about how trust or lack of trust of doctors contributes to health disparities?
Well, I think Dr. Cunningham touched on that a bit. Maybe she can elaborate a little bit more.
Yeah, so, there's, when we talk about mistrust, it's, again, very historically bound, right? And when we walk into any sort of situation with a provider, with friend, we have our own biases, our own thoughts, our own feelings. And then there are the biases of maybe that provider and their thoughts and their feelings. And it's actually when those two things kind of come together that we often see some changes and differences in care. Mistrust oftentimes leads to things like not following the directions of the provider. So if they make a recommendation for a certain type of medication for a certain period of time, a person may be very skeptical as to, I don't know if I should trust this. I don't know if this is what I needed. And we actually find that a lot within mental health care with individuals that are prescribed, say, their first medication, be it for depression, be it for whatever, they large time don't fill that first prescription. And it's only on subsequent visits with that provider that where they gain the trust, then they say, okay, I'll try. And it also impacts just the ability of saying you going to the doctor at all is something that's important. They maybe turn to other means, the internet, friends, family, other kind of cultural remedies, which again, in and of itself is not bad. But it's really making sure that healthcare providers specifically are aware of these things, aware of these possibilities, and ask, inquire, share, connect with your patient to be able to understand what their fears are, what their thoughts are being, what they've tried, and how medicine, be that behavioral therapy, pharmacological therapy, whatever the therapy might be, can coincide and add to for their overall benefit.
And yeah, I would also add that in our society, in our United States, we have a history of what happened to various populations, particularly racial and ethnic populations, that built up that trust historically. The famous cases of Tuskegee syphilis study, 1932, it still gets talked about in our country regularly, in which we did not provide proper care for in that experiment, which the federal government had to apologize for that experiment, and people are still talking about it today. Those are the major issues that happen in our country, and this is the reason why we're talking about, particularly in COVID now, will individuals take a vaccine now because they have distrust with our federal government because of things happened in the community years ago. So again, distrust is extremely important in all facets in working with communities of color.
Yeah.
Thank you, Dr. Bailey. Oh, go ahead, Dr. Cunningham.
I was going to add to that piece is that oftentimes people kind of focus back on Tuskegee. That's one that's definitely an incident that's very, but what's actually more interesting is that have been thousands of instances where their mistrust has been kind of laden in, and even those kind of the things that are not talked about, those individual sites and those things that feed into that. And if people want to be able to kind of get more information or kind of really understand the depth and the history of the things that the medical establishment maybe have done. Medical Apartheid is a great book to be able to kind of read and listen to, and it really outlines many of the other things outside of Tuskegee as well, which is often the one that's taught in school, to really get a true understanding of what's kind of gone on over the years.
Thank you, Dr. Cunningham. I just want to make note of one comment we had in the chat from a Dr. Ford Grant. I am a director at the CSLS, and a Husky dental disease is an epidemic we didn't discuss today, and there are great research opportunities here. So just in the last minute or so, I don't know if any of you want to comment on that.
Well, that's what I mentioned earlier about the community service learning centers.
Okay.
And Dr. Grant is running a wonderful program up in Ahoskie, along with the community health center right next door. So so this is a great program that the School of Dental Medicine has put together, really all across the state, but primarily in Eastern North Carolina. So I'm very enthusiastic about how this is addressing, many people don't have dental insurance. It's that, area for whatever reason in our country, we decided to separate health insurance from dental insurance. And so, a lot of people don't have health insurance. So the community service learning centers fill a tremendous gap in addressing oral health disparities in Eastern North Carolina.
Thank you, Dr. Bell. Well, I want to thank all of our panelists today. Thanks again to Dr. Bell, to Dr. Cunningham, and Dr. Bailey for sharing their expertise with us today on rural and public health in Eastern North Carolina. I'm sure they will be more than happy to answer any additional questions you have through email. And if you have any questions for us, please feel free to email Andrea Bristol, who's the head of our committee, bristol@ecu.edu. We thank you all for coming today, and we hope you have a great rest of the day. Thanks so much for joining us.
Thank you.
Thank you. Have a great day.